Hello, everyone. I appreciate the opportunity to be here today to talk about exercise on dialysis and if it's ready for prime time. So I'm going to start the talk today with a brief outline. Really, three things I'm going to cover. I'll start with a brief review and my interpretation of the past literature on exercise in dialysis. Talk about a little bit about the good and the bad. And then I'm going to move into discussing a couple of new studies that have come out in recent years that have some very intriguing data. I'm going to talk a little bit about whether or not the data is inspiring enough to really improve the implementation of exercise in dialysis. And then I'm going to finish up talking about some of the changes I think are needed and are coming in some future trials, really with a focus on three things. First being conducting larger studies with more important outcomes, getting patients really focusing studies on getting patients to move more instead of just mandated exercise prescriptions, and designing comprehensive intervention strategies really to address the multiple comorbid conditions that a lot of dialysis patients have. So the question today, of course, is, as my title indicates, is exercise in dialysis, is it ready for prime time? And I would say that the answer to this question is really that it is very complicated. Not a simple answer to this question. But I will say that not the way we've been doing things for the last 40 years, but I do think we are moving in the right direction. Suffice it to say that for those that are willing, patients that are willing to do it and able to do enough exercise, it has remarkable benefits. But really the problem comes down to the fact that we have not been able to get patients to do enough to realize some of the benefits that they could achieve if we could get them to do more. So the solution, though, we do have a solution to this. I think we're developing some new strategies, developing some policies that we know are needed, and we're working on these things now. Why is this really an important question to discuss? So in my opinion, if we do not acknowledge a lot of limitations with our current approaches to exercise for dialysis patients, the implementation of our programs are going to continue to be poor into the future. So just again, start off with a quick review of the existing literature on exercise and dialysis and what it suggests. First of all, I think most people are probably aware there have been dozens of research studies, more than 100 for sure, and review papers that indicate that exercise in hemodialysis patients in particular produces statistically significant improvements in a lot of things, including muscle strength, physical function, cardiovascular disease risk factors, quality of life, some patient-reported outcomes like cramping and fatigue. And this is regardless of the mode of exercise. So we do endurance exercise studies or resistance or strength training studies, yoga, balance, flexibility. Anytime we can get patients moving more, we tend to see some benefits. But there's also a lot of caveats in the data. The data is very inconsistent, and a lot of the studies are significantly flawed. There's small sample sizes, no controls, some other statistical issues with these studies. And the fact of the matter is the clinical significance of a lot of the findings have been questioned by many. And what I think is one of the most important caveats is that we know that participation and adherence to exercise programs are typically very low, and dropouts in the exercise studies are very high. And if we are being honest with ourselves, if the data on exercise and dialysis looked so good, probably exercise programs would probably be a lot more prevalent than they are today. So to kind of frame this conversation for the rest of the talk, I'm going to provide a case study of a 55-year-old African-American male who's been on dialysis for about 3 years. He's obese, hypertensive, sedentary, poor physical function, on a couple different blood pressure meds, has intradylic weight gain, about a little over 3 kilograms for 48 hours, chronic volume overload, and a lot of dialysis-related symptoms such as frequent interdialytic hypotension, cramping, and post-dialysis fatigue. And this is certainly the type of patient that we see in our clinics a lot. We ask ourselves, what is a reasonable exercise prescription for a patient such as this, and will it be effective? I'm going to try to make a case for why a typical exercise program that we normally do, something like interdialytic cycling or a walking program at home, is unlikely to produce robust benefits in a patient such as this. Why not? Well, one, a lot of patients are just not interested in doing a lot of exercise. Exercise capacity is low, and compliance and adherence to an exercise prescription is all likely to be low. But also it's important to understand this patient like a lot of patients, have some nutritional concerns that need to be addressed, in this case, chronic volume overload, before they are really capable of becoming a lot more physically active. So why is it so hard to get dialysis patients to exercise? Well, it's first of all, it's obvious that they have a lot of comorbidities. We know they have a lot of cardiovascular disease, vascular calcification, left ventricular hypertrophy, and heart failure. They have a lot of issues, chronic kidney disease, bone and mineral disorder, and a lot of muscle wasting. I'm also going to talk about, it's not just the muscle wasting that we think about, but sodium accumulation in the muscle might be contributing to this as well. So all these different comorbidities are all interrelated and really contribute to the low rates of physical activity in this population. So we think about sticking a bike in front of patients 2-3 days a week for about 20 to 40 minutes. One, can we get them to do it? And two, even if we can get them to do it, is it enough to really have significant benefits on all these different comorbidities? It's an open question. So to talk about this a little bit more, I want to provide some data from a study. This is a consort diagram from a study I was running a couple years ago. It was an NIH-funded trial looking at where we randomized people to the patients with 3 different groups: a control group, a whey protein supplemented group, and a group that got the whey protein plus the exercise was interdialytic cycling 3 days a week for about 30 to 45 minutes. What we want to emphasize here is what percentage of the patients in this study actually finished the program, and is this typical? So if you look at here, we screened 337 patients, and only 138 of them enrolled. So some weren't interested, some didn't meet the inclusion, some weren't cleared. Then we randomized them, and in the exercise group in particular, we had about 20 of the 49 drop out. So let's look at the characteristics of this population. It's pretty typical in the U.S. High BMI, high interdialytic weight gain, which may be contributing to some of the problems here. Due to some of the simple math here, the enrollment and dropout data is really informative. Only 40% of those screened actually enrolled in the study, and 40% in the exercise group dropped out. So if you look at the math on this, really, you multiply these together, and only about 17% of the dialysis patients are likely to finish a 6 to 12 month exercise program. This happened to be a 12-month program, but 6-month programs we see similar data. And even fewer adhere to the exercise prescription. Only about half of them generally do in most trials. So now we're down to about 8 to 9% of the population that we screen are willing to join a program and adhere to it. So we talk about exercise as medicine, but how good of a medicine is exercise the way we're currently prescribing? How good of a medicine is it if less than 10% of a dialysis population will take an adequate dose? I think this suggests that we have to do some things better. But despite all these concerns, we have some recent trials that provided really some reason for optimism. A couple of really robust trials I'll talk about: the Excite trial, the Cycle HD trial, and then 2 interdialytic cycling acute studies of interdialytic cycling that reduced myocardial stunning. I'm going to talk about these one by one in the next couple slides. So the Excite trial has been published in 2017. There's been several follow-up studies published, secondary analyses and whatnot. This generated a lot of excitement, if you will. A lot of publicity. It was a 6-month randomized trial in large sample size, one of the largest exercise interventions conducted to date in dialysis. It was an at-home walking program where the exercise prescription, generally speaking, was about 20 minutes a day, asking patients to walk 3 days a week, 20 minutes a day. And the primary outcome of this study was that they found that there was a dose-dependent improvement in physical function. What I mean by that, so whether you're looking at a 6-minute walk test or the sit-to-stand test, which is a measure of lower body leg strength, in the control arm, the 6-minute walk test change was not significant after 6 months, but even in the group that didn't exercise, didn't adhere to the exercise prescription, they were moving at all, they saw an improvement in 6-minute walk test, and the high adherent group actually saw a much more robust improvement. Same thing with sit to stand. If they moved at all, the sit to stand test improved, and if they were highly adherent to the protocol, it improved even more. So that's a nice finding. Exercise improves physical function. One of the things that got a lot of press is a secondary outcome in the study was that when they looked at all patients, they looked at hospitalization free survival, and in all patients, compared to the control arm, the active arm, there was no difference. But in the patients who finished the trial, there was a reduction in there was improvement in cumulative hospitalization-free survival in the active arm compared to the control arm. So reduction in hospitalization in patients who finished the trial. And what's even more important, I haven't shown this because the manuscript is in press now, but a follow-up study, a 3-year follow-up in this showed that there was a legacy effect where in the active arm, there continues to be, after 3 years, a reduction in hospitalizations in the active arm compared to the control arm. But I will note that a lot of the reduction that you see, it's more evident in the follow-up legacy study, that a lot of the benefit was seen early on. So after even 30 to 60 days of exercise, you saw this reduction in this improvement in mortality, which is a little bit hard to decipher, in my opinion. But so there are some caveats to this Excite trial. Again, much like the trial I performed, the enrollment, dropout, and adherence issues were evident. Only 40% of those screened enrolled, and this is typical. 30% dropped out after 6 months, and only about 50% were highly adherent to the exercise prescription. And the prescribed exercise dose was really low. They only prescribed about 60 minutes of walking per week, as I mentioned, and the realized dose was about half of that, again, which is typical. So to summarize, much the same as my study, 40% enrolled, 30% dropped out, half were adherent. So if you do this math, only about 6% of the patients in the sample had good adherence to the 60-minute per week walking program. And recognize the typical exercise guidelines are 150 minutes a week. So we're not asking them to do a lot. We can't even get them to do that much. So another thing that's been questioned is whether the improvements in the 6-minute walk test in particular, increase in 39 meters is clinically significant, statistically significant for sure, but there's some indication that there's a lot of variability in this test, and if 40 meters is really clinically significant, I think is an open question. And the hospitalization data, that look, it's encouraging, but it's really based on a small sample, and most of the benefit happened right after the start of the exercises, which it's to me, again, hard to decipher why that necessarily would be the case. So my take, I don't want to denigrate the study at all. It's a very nice study and provides some evidence of potential benefits for physical function, and for one of the first times in the literature, hard outcomes were improved, hospitalization mortality, from a very modest exercise prescription. But I do question whether the benefits are robust enough to change attitudes and our policies towards exercise in dialysis patients. And the fact of the matter is, the uptake of the exercise program was really low. So how can we get more patients to participate in an exercise program with even a modest exercise prescription? Another really interesting, exciting study that recently came out was a Cycle HD program out of the UK. This was a 6-month randomized trial, again, a relatively large sample size, one of the largest conducted to date, of intradialytic cycling, 30 minutes a day for about 3 days per week. Primary outcome in the study, they were able to show that in the exercise group, compared to the controls, the left ventricular mass was reduced by 11 grams at the end of the 6-month intervention. The secondary outcomes, there were some good and some bad. They also showed there was a reduction in arterial stiffness, a cardiac MRI, and that was a nice finding. However, along with several other studies been conducted lately, they did not show any improvement in physical function or quality of life, which is somewhat surprising perhaps to many, but if you really read the literature, this is a common finding in many studies. So my take on this study is that I think this is probably the best intradialytic cycling trial conducted to date. But again, are their findings robust enough to change policy or practice? Another study I'm really excited about, and there's 2 studies that show virtually the same thing. I'm going to highlight one out of Canada, but there was another one out of the UK, showed very similar results. And this is the study looking at the acute effects of intradialytic cycling on myocardial stunning. So myocardial stunning, small study, was assessed in 19 dialysis patients on 2 occasions using echo. First day was a control day, so patients did dialysis with no exercise, and the second day they did dialysis with intradialytic cycling for 30 to 60 minutes. And the primary outcome in this study is shown here. It was the number of stunned segments, which are regional wall motion abnormalities that are assessed by echo. There's a reduction at, we call it reduced at peak stress during dialysis. So at baseline, there are very few stunned segments, and then post-exercise, there's a little bit of a difference, but near the end of dialysis, The control group, more stun segments, more myocardial stunning than the exercise group. Then this is a really nice finding, important finding, I think. But my take on this study, there are some limitations. It was small. It was an acute exercise study that needs confirmation with a 3 or 6 month, for instance, robust training study. And this is a study that actually is in progress. It's an international group that's conducting this study now. The positive study is I really think is a really important novel benefit of interdialytic cycling that we didn't recognize. And if confirmed with the training study, the interdialytic cycling should, in my opinion, should be included as a core component of a comprehensive exercise intervention, not necessarily just have it interdialytic cycling, the intervention alone, but have a core component of a more comprehensive program. There's a good argument that can be made for that. So my summary of the existing literature in exercise and dialysis patients may differ from a lot of other people's, but the way I read things is that most of the existing literature does show modest benefits of exercise, but there are a lot of flaws, and I think the dialysis community has decided it's not inspiring enough to implement exercise programs in many places. Several recent trials, however, have provided some real good hope. The Excite trial and the Cycle HD trial, these are robust randomized trials that showed benefits. And these two pilot studies I mentioned in Canada and UK, that myocardial stunning may be reduced with acute exercise, is really important. But I have to say, I don't have time to go over all these now, but there's been some other recent robust trials that have not shown benefits. I'm not talking about them in detail here, but there's a study out of my lab, the iHope trial, study out of Australia, another study in the UK, the PEDAL trial that recently published. The summary of these three robust randomized trials that with exercise, interdialytic cycling, and at-home walking in the Australian study, so no changes in physical function, arterial stiffness, and quality of life. And these should not be ignored, even in light of these other trials that showed some benefits. My summary is that exercise in dialysis patients has many documented benefits, but there's a lot of caveats to this. And regardless of how one interprets the literature, implementation of exercise remains low. So how do we move forward? I have some ideas on that. So I want to start talking about what I think is trending and not trending in exercise studies in dialysis patients. Well, not trending are small studies with what I call boring mandated exercise prescriptions like interdialytic cycling or walking programs. I don't think people care about these types of studies. They're not producing the robust improvements that we need to see to implement exercise widely, to get the exercise community, nephrology community excited. In my opinion, the days where we've been sticking for 40 years, we've been sticking bikes in front of dialysis patients and calling an exercise prescription, and this needs to change. We can do better than this. What is trending is larger studies, and there's some international collaborations that are developing, one through the Global Renal Exercise Network that I'm involved in, to try to get larger groups together, combine their intervention protocols to produce more robust trials. And studies where we're really starting to change, where we're looking at more important and relevant outcomes to patients, these patient-reported outcomes like cramping and fatigue, hard outcomes like survival and mortality, and hospitalizations like was in the Excite trial, and some novel outcomes. I'll talk a little bit about myocardial stunning, I've already talked about, and muscle sodium levels, I'll talk about a little bit in just a little bit, and cost-effective analyses, really trying to show that clinics and or dialysis providers can save money if they implement exercise programs. Incorporating technology into a lot of studies is starting to happen. We're using virtual reality, activity tracking, especially related to trying to develop and deliver remotely delivered exercise programs, not just focusing on exercise in the clinic, but focusing on exercise for PD patients and home hemo patients, as well as outside the clinic for those who are in center dialysis programs. And exercise and physical activity prescriptions are now starting to move away from mandated exercise and really just focusing on getting patients to move more. And I'll talk about that some. The last thing really I'll talk about is interventions that are more comprehensive. So using lifestyle medicine approaches that include exercise, but also nutritional approaches and other behavioral strategies to improve people's health, improve patients' health. So Really want to focus for just a minute on these studies. I call them, we're doing interventions, just trying to get patients to move more instead of mandating specific exercises. We're doing one of these studies. Others around the world are doing something similar. We had a pilot study to examine the feasibility and efficacy of a novel patient-centered physical activity prescription in dialysis patients, look at its effects on physical activity, function, and quality of life. Methods in the study: this is a comparative effectiveness trial. We're comparing interdialytic cycling, in which we think will have some benefits, but not as many as we want, to this sort of move more approach. And our move more intervention it's 12-week intervention. This will include weekly one-on-one sessions with an interventionist to help motivate the patients, set goals for them, things like that. And what's important to recognize is that all movement counts. We develop a points-based system based on energy expenditure or MET value associated with different activities. For example, slow walking has been associated with MET value of 3.0. Won't get into the details of what that means, but essentially you get 3 points for every 10 minutes walked. Now, raking leaves, a little more high intensity for a lot of people. This has been assigned a MET value of 4. So you get 4 points for every 10 minutes of raking leaves, and you can do this for any activity you can imagine. And the program is progressive, so the goal is to increase weekly points. So you don't just get people moving and then have them continue to do the same thing. You want them to build on what they've previously done based on an individual's capability to exercise. We're doing some things to help motivate patients, such as engaging patients' family and friends, because a lot of people like to exercise with other people, and they'll do it more if they have that type of motivation. And our goal here is really try to, instead of mandating activities, we're trying to build habits and a support structure to allow exercise to work and to make it sustainable. And just very briefly, I want to provide some preliminary results from our first attempt at a Move More programs. It's somewhat informative. Now, this project was terminated by COVID, essentially. So it was only a 6-week pilot program, small number of patients, just to kind of develop the proof of principle here of what we're trying to do. So we did this program, and I want to just show you the weekly time spent on physical activity at the beginning of our program before we implemented the Move More intervention versus at the end. We saw a 5-fold increase in physical activity levels. Now, this isn't a lot of activity still, but it's better than what we were achieving after 6 months of interdialytic cycling, as an example. And even the functional assessment, we did a sit-to-stand test, and after the 6-week intervention, we're seeing a trend for an improvement in physical function. But that just shows a little bit of the promise. We are now in a Move More post-COVID phase 2, if you will, ongoing study. We got 35 people enrolled. It's a randomized controlled trial, it's this comparative effectiveness trial, as I mentioned. And there's also Move More type trials underway or planned, a really big one in Australia, a couple in Europe that I know about. So this is definitely a trend that's happening, getting away from mandated prescriptions to getting patients moving more. Another thing a lot of people are doing around the world is starting to try to develop programs that we can deliver remotely, exercise programs remotely. And this really started during COVID for obvious reasons. And also really so we can address the home hemo population, peritoneal dialysis patients, and trying to see if we can do this in a cost-effective manner. Again, just a sample approach that we're using. I'm working with a company called iSpin Health that has created a gaming platform to engage patients and create a community of exercisers. Develop a phone app that can track movements and physiological variables like heart rate and blood pressure. We're providing some kind of inexpensive cycles to the patients and exercise bands to get them doing all kinds of different activities. And one of the important parts about this, the cost effectiveness component of this, is we're trying to develop a model where we can get reimbursement from for the cost of this program from remote patient monitoring services. We've got some member incentive programs to engage the patients, and trying to get also reimbursement through some payer benefit programs. And to help motivate the patients, we're currently using health coaches trained in motivation interviewing to increase adherence with the program. But we are, the next step with this program is we're using machine learning to actually train a chat bot like Siri or Alexa or what have you to deliver the motivational interviewing remotely. So just a couple of things we're doing to try to develop remotely delivered exercise programs. I also mentioned that there's been a movement for more comprehensive lifestyle interventions instead of just exercise. So these things that include nutrition or other things as well. The reason this is so important is I believe we can try any strategy we want to try to get patients moving more, but we're going to struggle. I mean, patients are going to struggle because of all the comorbidities and other issues they have: poor physical function, fatigue, cramping, depression. Another barrier that doesn't talked about a lot with exercise is chronic volume overload or high inerdolic weight gain and the related cardiovascular comorbidities associated with that. The reason this is so important is because chronic volume overload in particular directly or indirectly affects many of these other barriers to exercise. The more fluid patient has removed during dialysis, the worse these symptoms. And we know chronic volume overload is highly prevalent, especially in U.S. dialysis patients. As evidence of its impact, exercise in third or fourth hour dialysis is often contraindicated due to cramping and inerdolic hypotension concerns, especially in patients that have a lot of excess fluid on them. So as a result of this, it's obvious that one of the ways to reduce inerdolic weight gain in particular is to reduce dietary sodium intake. So dietary sodium restrictions to reduce inerdolic weight gain may really be an important way of trying to help improve exercise capacity and adherence. So in light of this, so another reason, it's not just related to inerdolic weight gain, but another potential reason to reduce dietary sodium is to potentially reduce salt intake, salt levels in the muscle. So this is, if you're not familiar with this literature, a lot of it's been driven by Jan Tietze and some others. Um, but we know from their work and others that as we age in certain chronic diseases, salt starts to accumulate in our soft tissues, including muscles. This has really led to a new understanding of sodium metabolism, where the classic physiology has taught us that dietary sodium, we take it in, it gets excreted in the urine in 24 hours, but a number of work by a number of different groups recognize this probably isn't the whole truth anyway. Instead, we recognize that dietary sodium is temporarily stored in a number of tissues, including muscles. We know this. We can measure it using sodium MRI, shown here. And what happens in these immune cells will detect this stored sodium and promotes lymph vessel expansion to remove the stored sodium from the tissue and excrete it. But with age and with certain diseases, including chronic kidney disease, sodium clearance begins to be reduced from these tissues. And Chris McIntyre and his group has shown, this is an example, sodium concentration in the soleus muscle in controls versus pre-dialysis CKD, hemo, and peritoneal dialysis patients. Sodium levels are elevated in dialysis patients compared to these controls and non-dialysis patients. Question is, does this excessive muscle sodium, could it possibly be contributing to the muscle wasting and dysfunction in dialysis patients? I certainly think it might be. We know that dialysis patients, for example, have a reduction in contractile tissue compared to controls. We know that dialysis patients, the relationship between contractile cross-sectional area and muscle force is diminished. We know in dialysis patients, they have enlarged muscle fibers that may indicate fibroedema, and that they have mitochondrial swelling as well. And these, we don't know if they're related to the sodium in the muscle, but they certainly could be, and we're doing some studies to try to demonstrate that. So this is just an example of some of the things we can do with sodium MRI, our analysis tools. We can now distinguish the total amount of sodium from the intracellular and extracellular sodium in the muscle. If we put a person's leg in this sodium coil, in this example, we actually have them doing some exercises, some plantar flexions, but regardless, with sodium MRI, we can look at the morphology of the different muscle beds, and we can look at the total sodium signal, the signal in the total muscles, and look at the intracellular and extracellular components through our analysis. And just to provide an example of some of the things we're trying to look at, this is a study where we provided low sodium meals to dialysis patients for 2 months. Small sample, still ongoing, and we conducted sodium MRI on the calf muscles before and after we gave them these 2 months of the meals. And the results you see here, we looked at these 6 different muscle beds and a couple in the gastroc, and if you average all the muscles together, we saw trends for reduction in muscle sodium, mostly from the intercellular pool after his 2 months of feeding. So the question is, with a larger sample size, can we get significant reductions in muscle sodium, and will this lead to improvements in muscle function, which we think it might happen? This study is in progress. Another thing is will exercise during dialysis also reduce muscle sodium? This study also in progress. So wrapping things up, I just want to mention my take-home message is that I think we need comprehensive lifestyle interventions to prevent the cycle of disease and disability in dialysis patients. We've got to get away from this notion of these simple exercise programs, sticking bikes in front of patients or doing walking programs or simple resistance programs, to a more comprehensive lifestyle modification where we're getting patients engaged in low intensity and fun activities. Interdialytic exercise is important as a component of an exercise program, but also higher intensity exercise in those willing and able to do it. And we want these programs supported by the family, by clinicians, and also doing comprehensive interventions that include nutritional modifications. So we got to move away from mandated exercise prescriptions, focus on getting patients moving more. But for robust improvements, we also need comprehensive intervention strategies addressing nutritional concerns in particular. And this is going to get dialysis patients healthy enough to exercise more. So is exercise ready for prime time? I think it's complicated, but in my honest opinion, we're not quite there yet. We know it can work, but we haven't to date been able to get enough patients do enough to see robust benefits. We're on the right track. We got patients around the world getting patients moving more, doing comprehensive interventions. But in my opinion, if we want to see robust benefits that are going to inspire policy and practice changes to make exercise programs a component of the standard care of for dialysis patients, we've got to implement these more comprehensive intervention strategies, and this work is in progress. And with that, I just want to thank you for your time.